Hello, everyone, and good morning. Welcome to our conference. It is my pleasure to talk to you about a new field, which is cardio-oncology, chemo-induced cardiomyopathy, outcomes, and management. Oncology has been a very dynamic field, and there are plenty of new chemotherapeutic agents used to treat and prolong patients' lives. But we have to be aware that some of the patients have more risk factors, and drugs can cause or aggravate cardiac problems. It is therefore vital that we should be knowledgeable as to how to deal with this population of patients. And thus the objectives of this lecture is for us to be able to, one, identify patients at risk, to develop chemo-induced myocardial dysfunction, two, to know the recorded monitoring to stratify, identify early myocardial injury, and to forecast recovery. And number three, to initiate strategies for the prevention and attenuation of myocardial dysfunction. Chemotherapy-induced cardiotoxicity can limit the use of the chemotherapeutic agents. Cancer is not a death sentence. There have been increasing numbers of survivors. 67% of people diagnosed with cancer today will be alive in 5 years. 75% of children diagnosed with cancer today will be alive in 10 years. Chemotherapy is an adjunct or primary therapy for various cancers, but also carries risk for cardiotoxicity that can limit its use and can be life-threatening itself. This pie chart reflects that not all cancer patients die from the disease itself. A significant number succumb to other causes, and a good 33% die from a cardiac problem. In view of these trends, as well as the cardiovascular toxicity potential of radiation and chemotherapy, cancer patients are exposed to cardiovascular morbidity and mortality more than ever before, thus generating the call for oncocardiology or cardio-oncology. This is a cardiovascular subspecialty focused on identifying, preventing, and treating cardiovascular complications of cancer therapy. The American College of Cardiology recognized this as one of the top cardiology stories for 2014. The first approach is clinical risk assessment. We cannot and should not forego the basic clinical history and physical examination. And then we get guided by the objective parameters, which is the ECG, the 2D echocardiogram, and the global longitudinal strain assessments. These give us a quantitative evidence as to the cardiac status, with the objective to and at least keep it the way it is, if not to improve on it. The cardiac biomarkers, which are exemplified by the troponin and the natriuretic peptides, can be used especially in high-risk patients. High risk is determined by the number of cardiovascular risk factors and their severity. So we need to get the history of a patient with current myocardial disease, like heart failure, asymptomatic LV dysfunction, evidence for coronary artery disease, moderate and severe valvular heart disease with LVH or LV impairment, hypertensive heart disease with LVH, hypertrophic, dilated, and restrictive cardiomyopathy, cardiac sarcoidosis with myocardial involvement, and of course, let's not forget the significant cardiac arrhythmias. Also important would be a previous cardiotoxic cancer treatment history, like prior anthracycline use especially, or prior radiotherapy to the chest or the mediastinum. The demographic and the other cardiovascular risk factors. More significantly will be the age, especially the more senior citizens, like more than 65 years old, are more prone to cardiotoxicity with the use of anthracyclines. The family history of premature cardiovascular disease, arterial hypertension, diabetes, and dyslipidemia. The lifestyle risk factors, history of smoking, high alcohol intake, obesity, and a sedentary habit. This is a quick summary of a risk stratification. Baseline risk is low if the patient has no clinical risk factor, with a normal ECG and a normal echo. So the follow-up will be the standard recommended schedule. An example would be just to re-evaluate the patient after 200 milligrams per meter square of anthracycline. Since the follow-up is dose-related, so we go by the dose of anthracycline. And for the trastuzumab, every 4 cycles, or that should be like every 3 months. High-risk patients has clinical risk factors, like more than 65 years old, has comorbidities like hypertension, diabetes, dyslipidemia, and other valvular heart diseases. With an abnormal ECG, we look for an arrhythmia, LVH, changes that suggest ischemia, or an abnormal baseline echo, where we note for structural changes like LVH, valvular heart disease, and wall motion abnormalities. And most especially, left ventricular ejection fraction. So this population will need cardioprotection, as will be discussed in a while. Chemotherapy-induced cardiotoxicity fall into 4 categories. One would be the cause, would be the direct cytotoxic effects of chemotherapy and associated cardiac dysfunction. These are exemplified by alkylating agents, anthracyclines, interferon alpha, monoclonal antibodies, and the tyrosine kinase inhibitors. The anti-tumor antibiotics, the fluorouracil, would cause cardiac ischemia. The anthracyclines are noted to cause cardiac arrhythmias. Pericarditis could be caused by bleomycin, cyclophosphamide, and cytarabine. So these are the chemo agents that have particular potential to cause specific cardiac problems. It is not part of our discussion as to the different indications as to when the different agents are used for. It is advantageous, though, to know which drug the oncologist will potentially use, so it will be easier for the cardiologist to anticipate problems. Example would be the anthracyclines or the anthraquinones will most likely cause congestive heart failure, LV dysfunction, myocarditis, and arrhythmia. The antimetabolite agents would most likely cause ischemia, pericarditis, congestive heart failure, or even cardiogenic shock. The antimicrotubule agents most likely would cause arrhythmias like sinus bradycardia, ventricular tachycardia, AV blocks, or it could cause hypotension, congestive heart failure, and ischemia. Hypertension and arrhythmia can be caused by the anti-angiogenic and tyrosine kinase inhibitors. Monoclonal antibodies, exemplified by the trastuzumab, will cause arrhythmias, congestive heart failure, and LV dysfunction. Alkylating agents, most exemplified by the cyclophosphamide, would most likely cause neurohormonal activation. This involves the activation of the sympathetic nervous system and the enhanced release of vasoconstriction and the sodium-retaining neurohormones like angiotensin II, norepinephrine, vasopressin, and it is an important mediator for the cardiorenal syndrome in acute decompensated heart failure. This is a graphic presentation to show how excessive neurohormonal activation can be detrimental. The increase in the sympathetic nervous system activity can induce significant vasoconstriction. That can reduce the blood flow to the limbs and can cause ischemia. The increase in renin, angiotensin II, and the vasopressin secretion can cause a reduced blood flow, which could be a contributory factor in patients with cardiorenal syndrome in decompensated heart failure. This is just to show the frequency of the use of the chemotherapeutic agents, its frequency, and of course the percentage of incidence. As we go through each of them, like the anthracyclines, They have a high frequency of use and a high incidence percentage of 26%. The alkylating agents, most exemplified by the cyclophosphamide, has a high percentage incidence of like 28%. The antimetabolites and the antimicrotubule agents. The rest would be the monoclonal antibody-based tyrosine kinase inhibitors, most exemplified by trastuzumab, has a high incidence of 28%, and so on. So it is important to communicate with the oncologist as to the specific drug that will be used and the frequency and dosing so that proper schedule or follow-up can be possible. How does anthracycline cause cardiotoxicity? It is due to the reactive oxygen species formation, the site-specific DNA damage. Oxidative stress induction can induce DNA and sarcomere damage. Mitochondrial dysfunction mediating death of cardiomyocytes. Another mechanism would be sarcomeric structure disruption or toxic accumulation of metabolites. And of course, inflammation. These are the most commonly used agents that can cause myocardial ischemia. The antimetabolites, most especially the fluorouracil, has a high incidence of up to 68%. This is due to the endothelial injury and the vasospasm. Up to 18% manifest as myocardial ischemia and like 70 to 10% as silent myocardial ischemia. The monoclonal antibody-based tyrosine kinase and the small molecule tyrosine kinase inhibitors can cause endothelial injury. They are also procoagulants, which may lead to arterial thrombosis. So these are the agents that could cause bradycardia and prolonged QT syndrome, the agents that cause bradycardia, and the agents that cause prolonged QT syndrome. But it is important to remember and consider that QT prolongation may also be caused by other factors, like electrolyte imbalance. Since most patients would feel like vomiting, they have diarrhea, and some in patients in overt heart failure may be using loop diuretics, so they should be monitored frequently. Some also would have a family history because prolonged QT syndrome could also be genetic. We should also get the history or workup for patients for hypothyroidism, the use of other concomitant medications. Now, the management of prolonged QT syndrome that is defined as more than 500 milliseconds or prolongation of more than 60 milliseconds from baseline is generally dependent on correcting the predisposing factors. Development of torsade de pointes is unusual, but if it occurs, IV magnesium of 10 ml or sometimes an overdrive pacing may be needed. If ventricular arrhythmia is sustained and with hemodynamic instability, defibrillation may even be performed, such that it is important to remember that hypokalemia and extreme bradycardia is to be avoided. So these are the agents that could possibly cause hypertension and thromboembolism. Now, this varies, the incidence would vary significantly, especially in the angiogenesis inhibitors. It is very dependent on the patient disease status, the use of dexamethasone, and other chemotherapeutic agents that are used during the study period. Now, cardioprotective agents. The most available here or easily available would be the selenium, which is used as an antioxidant agent. Ranolacin, we often use this as a selective inhibitor of the cardiomyocyte late inward sodium current. It's also used as anti-ischemic, anti-arrhythmic, and ATP sparing actions. The statins, and of course the beta blockers. Most studied are the carvedilol and the nebivolol, which is used as an antioxidant and for their anti-apoptotic effect in congestive heart failure. CTR-CD, or cancer therapy-related cardiac dysfunction. The diagnosis of choice would be echocardiography. This is defined with an LV ejection fraction. More than 10 percentage points decrease to a value below the lower limit of normal would be significant. According to the American Society of Echocardiography and the European Association of Cardiovascular Imaging, this is defined, the lower limit of normal is defined as less than 53%. According to the ESC, the lower limit of normal is less than 50%. And lately, we've been using global longitudinal strain. This is a change in length of the myocardium during systole. So this is expressed as a negative percentage. The more negative, the shorter the myocardial length assumes, therefore reflects good contractility. This has been proven to be more sensitive in picking up early or subclinical myocardial dysfunction more often than the more often used left ventricular ejection fraction, such that subclinical myocardial dysfunction can be detected. This is defined as more than 15% relative increase of the percentage reduction from baseline. Now, the lower limit in our heart station is usually negative 18%. The reversibility of LV dysfunction is associated with early initiation of heart failure therapy after the onset of cardiotoxicity. That's why this has been claimed to be more sensitive than the LV ejection fraction, so it would better benefit the patients. A biomarker is an indicator of objective measurement used to detect diseases and risk. They are used to identify patients who would most likely benefit from ACE inhibition for cardioprotection. But then, the routine role of NT-proBNP and the BNP in surveillance of high-risk patients still needs further investigation. These are more useful than the troponin, cardiac troponin in the early identification of high-risk patients. This is just a minimum recommendation for monitoring for myocardial dysfunction. It is already stressed enough that prior to cancer therapy, we take the baseline risk assessment with a baseline echo and the baseline ECG. Now, during the cancer therapy, let's go give you an example. Trastuzumab, you go every 4 cycles or every 3 months. Or with doxorubicin, which is dose-related, we go after evaluation after 200 milligrams per meter square of doxorubicin. We do clinical evaluation with an ECG and echo. But then, this is just the minimum recommendation. It can be done more frequently if needed, especially when there is a change in the clinical status of the patient, like when the patient complains, have suggestive of ischemia, arrhythmia, or heart failure. Okay, so after cancer therapy, follow-up would be 1 year after and 5 years after. Of course, the frequency of surveillance is determined by the healthcare providers based on the clinical judgment and the patient circumstances. Let's note the different stages of heart failure. Once heart failure is detected by echo, cardiac imaging should be done every 2 to 3 weeks and then categorized as symptomatic or asymptomatic. Stage A would just be those patients at risk with no structural heart disease. With structural heart diseases are stages B to D. Stage D is refractory heart failure, which could require specialized intervention. The use of cardiac biomarkers may be considered to detect early cardiac surgery. An abnormal biomarker result could be indicative of an increased risk of cardiotoxicity. So stage A, all we need to do is just treat hypertension, dyslipidemia, diabetes, stop smoking, and stop alcohol and other drug use. Once the patient has structural heart disease, and even if the patient is asymptomatic, we can use cardioprotection with beta blockers and the RAS inhibitors. With the patient in overt decompensation, we can use diuretics, digitalis, unloaders like the hydralazine and the nitrates, even biventricular pacing or an ICD. Stage D is intractable heart failure, compassionate end-of-life care. Extraordinary measures like heart transplant, chronic inotropes, permanent mechanical support, and experimental drugs or surgery will just be presented to the patients and the family, because in the end, it is still their choice as to how far they want to go so far as the management and interventions are concerned. This is a study published in 2015 where they studied 2,625 patients who were treated with anthracyclines. This is their protocol for the follow-up of patient. An echo was done baseline every 3 months during chemotherapy, first year after completion, and every 6 months for 4 years, and then after that would be yearly. Dysfunction was noted in 9% of patients. 98% detected within the first year of chemotherapy. Now notice that they were all started in cardioprotection, and a good 82% of the patients recovered. So it is just prudent to follow up patient closely so that we can have an early cardioprotection. As stated earlier, a baseline assessment is done prior to initiation of potentially cardiotoxic cancer therapy. And of course, this entails echocardiogram and GLS, or the global longitudinal strain. Now, in patients with normal LV systolic function, optimal correction of the cardiovascular risk factor is the only approach. In patients with borderline ejection fraction, like 50 to 59%, we are guided by the GLS. If the GLS is more than 16%, this suggests preserved systolic function. If the GLS is less than 16%, or there is a more than 15% drop from baseline, this suggests subclinical LV dysfunction. We still need further studies as to guide specifically cardioprotection in early subclinical myocardial dysfunction based on the GLS. But then, the treatment therapy should not be stopped, interrupted, or reduced in dose based on the new GLS reduction alone. When the systolic dysfunction is determined with an EF of 40 to 49%, there is definitive indication to start cardioprotective medications. Now, with an EF of less than 40%, the patient should be discussed with the oncology team, and options for non-anthracycline-containing chemotherapy should be considered, or rescheduling or the next doses of chemotherapy. This is the SOCOR trial. It's called SOCOR, Strain Surveillance Chemotherapy for Improving Cardiovascular Outcome. This is a multi-center trial which is randomized and controlled. This is a study on patients. They started with 320 patients with at least one risk factor. They were randomly allocated to GLS and ejection fraction. Now, the purpose of this study was to compare the usual care, which is guided by LVEF, and the conventional criteria for the diagnosis, which is dependent on the symptoms or the recognition of heart failure symptoms. Now, they noted that if you use the GLS, it had an earlier pickup of patients with subclinical myocardial dysfunction, such that cardioprotection was started earlier in 15 out of 40 patients compared to those guided with the LVEF, where the cardioprotection was given in 4 out of 46 patients. So this just proves that the GLS could pick up earlier and would be more sensitive to subclinical myocardial dysfunction. So if a patient has a significant decrease in EF with a decrease of more than 10%, LVEF of less than 45%, but to a value that does not drop below the lower limit of normal, the patient should undergo repeated assessment of the LVEF, which can be done every 2 to 3 weeks, shortly after and during the duration of the cancer therapy. However, if the LVEF is less than 45, there is always a choice either to interrupt and start ACE inhibition and beta blockers, or to continue therapy and start ACE inhibition and beta blockers. So there is no clear recommendation regarding the continuation or the discontinuation of cancer therapy with evidence of cardiac dysfunction. This decision can be made with the oncologist and should be informed by close collaboration with a cardiologist, fully evaluating the clinical circumstances and considering the risk and benefits of continuation of therapy responsible for cardiac dysfunction. With significant dysfunction, it may be interrupted and could reinitiate the chemotherapy when the LVEF is more than 49%. Now, when do we initiate cardiotherapy? These are the treatment options to prevent or recover from CTR-CD. Patients who are high risk or anticipated doxorubicin use of more than 250 milligrams per meter square. It is okay to start before cancer therapy. Patients with elevated troponin. Patients with asymptomatic reduction in EF. It should be given within the first 6 months after the end of chemotherapy, because if it is started earlier, there is increased likelihood of LV recovery of the function. Asymptomatic reduction of GLS. This is an earlier pickup of the subclinical myocardial dysfunction. Now, this is another study, which is a double-blind, multicenter, placebo-controlled trial. They studied patients for 2 years. Patients who had breast CA treated with trastuzumab with or without the anthracycline, where they used lisinopril versus carvedilol versus placebo. It has been noted that the use of lisinopril and carvedilol were effective in the prevention of the trastuzumab-induced cardiotoxicity in patients, especially receiving anthracyclines, where cardiotoxicity was noted in 38%. With the use of cardioprotection, this was reversed or corrected in 50% of the cases. So these are the treatment strategies and the studies that would support the use of cardioprotection with beta blockers, where the carvedilol is used at 25 milligrams twice a day, the nebivolol at 5 milligrams once daily. It showed there was an increase in ejection fraction, an improvement in the diastolic parameters, and of course the NT-proBNP. These studies support the use of RAS inhibitors, like the valsartan was used at 80 milligrams in these studies, enalapril at 20, telmisartan at 40 milligrams per day. This prevented transient increase in the LVED, the QT prolongation, and the BNP. There was no decrease in the LVEF, and the GLS normalized in 6 months. These studies used enalapril and carvedilol. There was a reduction in the heart failure. When metoprolol was studied against enalapril, it was shown that there was no benefit using metoprolol. The possible mechanisms for the effect of the third generation beta blocker, which is highly selective, are the carvedilol and the nebivolol, has an additional cardioprotective properties via their peripheral vasodilatation, mediated by the nitric oxide pathway. It has also antioxidant and anti-apoptotic effects. Let's apply our recommendation to an actual patient. So we have a patient, 44-year-old, with no cardiovascular morbidity, non-smoker, no family history of premature heart disease. So this is practically low-risk patient. The patient had uterine leiomyosarcoma, post-robotic hysterectomy, bilateral oophorectomy. Now, 6 months prior, patient underwent doxorubicin therapy at 360 milligrams per meter square. Initially, the patient had a good wall motion contractility with 57% ejection fraction. Now, 2 months after the completion of chemotherapy, the patient developed heart failure symptoms. So the patient came in, got admitted. The patient was in distress, in overt heart failure with neck vein distension, crackles bilateral from mid to base, and grade 1 bipedal pitting edema. Patient was dyspneic with an ejection fraction of 19% and global hypokinesia with a very high NT-proBNP of 16,158. So the patient was admitted. So this was the baseline, which is low risk. And 2 months after the chemo, the patient developed heart failure symptoms with a significantly high pro-BNP. Now, heart failure therapy was started in our institution. And 7 months after the heart failure therapy, with the use of the valsartan and sacubitril and the beta blockers nebivolol, the ejection fraction improved significantly, and the patient was able to perform 9 METs of the stress exercise test, and the pro-BNP reduced to 267. So this was the initial global hypokinesia of the patient, and this is post-therapy, where there is significant improvement of the LVEF. The patient was seen at the ER about 2 months after the chemotherapy in full-blown heart failure. The patient significantly improved after 7 months of heart failure treatment and is presently doing much better and trying to go about her usual obligations and role in life. This was the latest global longitudinal strain. We usually take it in 3 views: the apical 3, the apical 4, and the apical 2 chamber. The average global longitudinal strain, which is negative 16.2. This is slightly decreased compared to our normal, which is negative 18%. So the role of ARNI, or angiotensin receptor neprilysin inhibitors in CTRCD, has been approved for patients with heart failure. So these are the studies that shows that its combination in the treatment of trastuzumab-induced cardiomyopathy and anthracycline-induced cardiomyopathy is useful for LVEF normalization, and it has minimal side effects and would require no more hospitalizations. The message that we want you to take home are the following: early identification of patients at risk to develop CTRCD with GLS, and outcomes of early initiation of cardioprotective therapy with the use of ACE, beta blockers, ARNI. Patients in overt heart failure will benefit from diuretics and digitalis. And let's not forget cardiac rehab in the management of CTRCD. Regardless of our field of expertise, we have one shared goal: cancer survival without cardiovascular disease. So let me express my appreciation and congratulations to the hardworking organizers of this conference. And again, thank you so much and have a great day.
Thank you, Dr. Sharon Lacson, for the comprehensive overview of cardio-oncology and cardiotoxicity related to chemotherapy. Uh, Let me ask the first question, Sharon.
Sure. Hello.
Um, Hi. In your guidelines, we initiate cardioprotection for patients after controlling the risk factors. We initiate other treatments when there is evidence of subclinical LV dysfunction. So that's understandable that we control hypertension, diabetes, dyslipidemia, smoking. But what about those younger patients who have no risk factors, just like the patient that you presented? She's just 44, and in 6 months after treatment with doxorubicin, she developed uh, overt heart failure. My question is it prudent to start uh, patients with cardioprotection already at the initiation of this powerful chemotherapy like doxorubicin, cyclophosphamide, anthracyclines? Because I think it will make sense because these agents like beta blockers can control neurohormonal activation. ACE inhibitors or ARBs can improve or can protect the endothelium, prevent oxidative stress. So, does it make sense to start them simultaneously with the initiation of chemotherapy?
Yes, thank you so much for that question. That's why it is important to communicate with the oncologist because that would depend on the dose of the drugs. So if they're put like in a higher dose, it would be prudent, especially in patients with very high dose, to start with low dose cardioprotection. Because just like in the patient that I presented, the patient was literally low risk. And another message would be frequent reevaluation, especially when you note that the dose is already high. The usual would be 3 months, 6 months, and then 9 months. But any time in between where there is any change, that's why we go for the GLS, which could pick up early myocardial dysfunction, even if the patient is asymptomatic. Then we can start with cardioprotection when there is any change with the GLS. But the message there is you don't need to stop chemotherapy, you don't need to alter medications. If the GLS starts reducing, you can monitor more frequently, every 2 to 3 weeks even, and then start your early start of your cardioprotection at that point in time. So it is very important to communicate with the oncologist because the follow-up is not really very literal, like every 3 months, 6 months, because it's always the message is take into consideration the patient. If the patient becomes symptomatic or there is by any chance the GLS reduces, so you do every 2 to 3 weeks evaluation.
We have a question here that is actually related to my question from a dear classmate and friend, no, Dr. Lopez.
Yes.
Will you recommend starting patients who will have chemotherapy on low dose beta blockers or ACE in at risk patients?
Before we get to there, while we're waiting for Dr. Lopez, there's a question about coronary angiogram. That's a very significant question because especially in patients showing signs of ischemia, patients who are symptomatic with chest pain, patients with risk factors that could lead to coronary artery disease. coronary angiogram should be entertained, especially if the expected life expectancy is good. So in patients where the patient becomes symptomatic, you have a good suspicion for coronary artery disease, you can go for coronary angiogram. Now, the very interesting question is, what if there is a significant obstruction and the patient has, number one, high risk for bleeding? So you would be very cautious with the stenting, because the patients who are on chemotherapy, they are like high risk for bleeding, especially colon cancer. And then they are usually with low platelets like thrombocytopenia, bone marrow depression. So the recommendation, this is very good that someone brought this up, because if there is an acute coronary syndrome or acute myocardial dysfunction that requires revascularization, it is recommended that we just do angioplasty, balloon angioplasty. But if there is like a leeway to delay any intervention, so we can use even just bare metal stents if we can postpone any intervention. Because sometimes patients are referred to us um, for surgery. Of course, we cannot keep on delaying the surgery because the patient needs early surgery in patients, especially with advanced cancers. So when you do coronary angiogram and there is a significant obstruction, the recommendation of AHA and ACC is just to do um, angio, balloon angioplasty, because there is a very delicate balance in these patients between bleeding and thrombosis. So you have to like know how to balance those with the use of your antiplatelets and your anticoagulants. Another factor that is interesting, which I did not have time to mention, what if this patient has atrial fibrillation? You would be using your NOACs, but you have to be careful about it, because these patients, as I mentioned earlier, have an increased risk of bleeding. And the usual has bled scoring, like we say, we use with caution if more than 3, this is not very representative in this patient, because these patients are a special population of patients with increased bleeding, especially with their thrombocytopenia and their bone marrow depression. And especially in patients, as I mentioned earlier, cancers, sites which are prone to bleeding, like colon CA. So you have to be very careful. It's a delicate balance between bleeding and thrombosis.
We have a question from an oncologist, Dr. Belen Tamayo. What
Yes,
is a significant decrease in GLS which will require a repeat 2D echo after 2 to 3 weeks?
decrease to less than 16%. Our normal actually is negative 18% in our heart station. Now the decrease to less than 16% or more than 15% decrease, that should be like 15 to 16, minus 15 to 16% GLS. So we would go for more frequent evaluation.
Okay. A follow-up question from Dr. Eleanor Lopez.
Yes.
Will follow-up protocols be affected by those who had radiotherapy?
Yes. Radiotherapy and previous use of this anthracycline and drugs. Follow-up therapy, the usual would be 1 year and 5 years for the usual with no complications at all. But if you take into consideration age, other risk factors, other changes from the baseline, then one would go more frequently, like every year. But if there is any change at all, then that would change the frequency. The protocol for follow-up is not actually that strict, because as I stressed earlier, it's always related to um, how the patient is at the moment of evaluation. So if there is any change, you go for more frequent evaluation. But barring any change, you can go for an annual evaluation. Then after 3 years, you go for longer evaluation.
Okay, a follow-up question from our oncologist, Dr. Tamayo. Breast
Yes.
and lung cancer are the most frequent cancers in the Philippines. So we use a lot of anthracyclines, trastuzumab, and antimicrotubulin. A lot of our patients are also young patients who fortunately do not yet have hypertension, heart problems, and have normal 2D echo and GLS. What is the optimum frequency of monitoring 2D echo with GLS?
So as I mentioned earlier, if it's the trastuzumab, during therapy, it is like every 4 cycles or every 3 months. With the anthracyclines, it is dose related. So most especially if you go more than 200 milligrams per meter square, then you go for frequent follow-up. When I say frequent follow-up, that depends on the status of the patient. Either every 2 to 3 months, if there is any change, then you go every 2 to 3 weeks during therapy. I
From
hope I hope you're getting the picture.
from
Dr. Tamayo.
uh,
No, it's okay. You can ask questions.
now, which chemotherapeutic drug will you possibly recommend to as a preventive cardioprotection even on low-risk patients?
No, low risk patients, we
From
just
Dr.
treat.
Bernardo.
My question, doctor, is for example, in your patient, she was actually low risk, correct? So
Yes.
there are certain chemotherapeutic agents that are have much higher cardiotoxicity than others. And my question is there any role in giving preventive cardioprotection in these patients who will be receiving such chemotherapeutic agents? And what are those chemotherapeutic agents that usually have a higher risk of cardiotoxicity? Thank you.
Yes, the highest risk are the anthracyclines, the trastuzumab, when you talk about LV dysfunction. So there is a protocol or a suggestion that if very high doses are used, you can even start with cardioprotection, like your beta blockers, just to protect the patient and more frequent follow-up. The message is we should know which ones are more cardiotoxic, and we do more frequent follow-up, especially whether it is dose related or after 4 cycles of the trastuzumab.
Okay, thank you, doctor.
Another question from Dr. Torres.
Yes.
Will we continue anti-heart failure medications once systolic function recovers as measured by parameters like EF, GLS, wall motion abnormality?
As long as the patient is on chemotherapy, we continue our medications. Now, it is evaluated after patients with LV dysfunction every 6 months after the chemotherapy. Now, the leeway period is always 1 to 3 years. So you get an observation of 1 to 3 years because as we noted in the presentation earlier, there was an 82% recovery of LV function.
But I just want to share, I just received clearance for chemotherapy, and I saw that all the drugs are all cardiotoxic. This is a
Yes.
low-risk patient, um, but she will get doxorubicin, and it's triple cardiotoxic drugs. So I told the patient, wow, we might need to monitor you more closely.
Yes.
A very sensible question that she asked. Can you give me something to protect my heart? So she's low risk. So I gave her small dose of a beta blocker, small dose of an ACE inhibitor, and trimetazidine. This is like, much like getting a vaccine. You are protected from the onslaught of these powerful chemotherapeutic agents. So um, that may be out of the box, Sharon, but sometimes if you're aware of the high high potential for cardiotoxicity, you you need to do something to at least attenuate the adverse side effects. We don't want our patients to die of cardiac complications because of treatment for cancer. Because it's that's a very sad scenario, when you hear families na hindi po naman namatay sa cancer, namatay ho siya dahil
Heart.
sa gamot, dahil sa gamot. So that's a very sad scenario. And we see that in our practice.
Yeah, that's not actually out of the box because we are preparing the patient, especially with the high dose cardiotoxic cardiotoxic
Yeah.
medications. It is only prudent to protect our patient. So it is not out of the box because it is a recommendation if you are already facing with high dose um, cardiotoxic
Yeah.
agents, you can go for. But I never went across the use of trimetazidine. The recommendation that saw was ranolazine. So, but they have more or less similar effect.
Similar, yeah. It's a metabolic agent.
Yes.
So um, your lecture really stimulated a lot of reaction because these are the patients that we see in the clinic. So thank you, Sharon. And at this, do we still have questions?
Those are the ones I presented are even the simple ones like just LV dysfunction. It becomes more interesting and challenging with patients with acute coronary syndrome. So you have to decide whether just to do balloon angioplasty, whether to go for bare metal stents, and to make it more complicated, I had a patient who needed urgent surgery for the cancer, but very unfortunate that he developed acute coronary syndrome. So you have to address that, but you cannot use the usual drug-eluting stents that will require multiple anticoagulation. So you just have to be content with temporizing and just do balloon angioplasty. But you have to address the ischemia before the surgery. So it becomes more challenging and interesting if there is an interplay of other factors, like, as I mentioned earlier, arrhythmias, atrial fibrillation, and you get a play of bleeding and thrombosis. I'm sure Dr. Bernardo see a lot of these patients where you get to balance anticoagulation versus bleeding.
Yes, doctor. I see a lot of those patients, because cancer therapy and radiotherapy does not only cause cardiac dysfunction, it also causes um,
Venous
VTE,
thrombosis.
venous thrombosis, and lymphedema, which are also life-threatening for patients. And
Yes.
there are certain NOACs that we prefer over other NOACs when this kind of cancer, for example, is present versus another kind of cancer. Thank you, doctor.
Let's entertain two more questions. A follow-up question from Dr. Eleanor Lopez. Are cardiac changes post-chemo reversible?
Yes, there was a study that if you do early intervention is like 6 months after chemotherapy, 82% recover. So the rest, we would say only God knows because there's no clear data so far as that 12% is. But the message is always do correct within 6 months after chemotherapy. So right after chemotherapy, it is only prudent to do examination 3 months and then 6 months after to pick up early those patients not responding well.
So maybe last question from Dr. Tamayo. There is increasing information in our anti-cancer drugs, which can cause QT prolongation. A lot of our clinical trials show that while QT may prolong, it did not translate to a clinically significant cardiac sequelae like a torsades-de-pointes. Are there any telltale signs and symptoms that can guide us as far as prolonged QT interval is concerned?
Prolonged QT syndrome it's always important to know the background. Number one, genetic, as I mentioned earlier. Number two, the other, it could not always be due to the drugs, due to the concomitant electrolyte imbalance, due to the other non-chemo drugs. Like for example, very noted are the antipsychotic drugs, antidepressant drugs, which could cause the QT syndrome. So you have to go through what are the causes of QT syndrome, and you have to check it up, and you have to correct that. It's not just because you cannot do anything with that. You just have to observe and to prevent further arrhythmias. But more importantly is to take out all the contributing factors that could lead to prolonged QT syndrome.
Okay, I think the attendees have been satisfied with all the answers. Sharon,